So let's break this down to the fundamental components. To answer your question, the purpose of Obamacare, because he knew it wouldn't hold down costs. I mean, this was predicted. I'm sitting there in Oshkosh. I mean, that's why I ran for office. I knew this would be a miserable failure, right? The reason Democrats passed Obamacare is because they wanted it as the next step to a single-payer system, which is why they had the federal government pay $9 for every dollar the state spent on a single, able-bodied, working-age, capable adult, right? Which has led to all kinds of massive fraud. And quite honestly, really caused states to structure their budgets around it, hospitals to structure their budgets around it. So when we try and reform it, like Senator Scott was going to do, is let's just cap it. If you want to, as a state, cover single able-bodied, fine, but not a 9-to-1 match. Do like you do a disabled child. $1.30. So again, the fundamental of Obamacare was this is our way to get to a single-payer system. But let's talk about the fundamental flaws, why it didn't lower costs. Consolidation of industry. It led to that, which, by the way, the cost of employer sponsors plans is a lot lower than the exchanges, but it's still way too high. And I've got to think that the flawed part of the consolidation contributes. So there's no reason for insurer plans to be almost double the rate of inflation. So again, talk about the consolidation of the industry as succinctly as you can is one of the fundamental flaws of Obamacare.
Yeah, I think to answer your question, the law creates this one-way street into government-run healthcare. That's absolutely true. Once the small businesses drop their coverage, they generally don't come back, which is a huge problem. In the consolidation space, though, what we saw was, again, massive consolidation in the insurance markets and massive consolidation in hospital markets. That hospital market consolidation drove up prices by 15 to 30%. That flows directly through to premium.
And again, that's just basic economics. When you have less competition, people kind of look around and go, oh, we can charge that, we get away with it. And also the medical loss ratio, there's no incentive to reduce costs anywhere along the supply chain, right? There's absolutely no incentive to reduce costs.
It's worse than that.
It's all to increase costs.
The medical loss ratio actually encourages higher premiums, as Dr. Blaze indicated. It also creates incentives for insurers to buy practices, which they've done, and pharmacies and PBMs, which further consolidates the market because they can drive revenue through those entities that then allows them to avoid the cap on profits. So it further consolidates the market and drives up costs across those markets. All those costs bleed over into the employer market. I think what you see in the difference between the 168% increase in Obamacare and the 78% increase in employer markets is the employers are not subject, the large employers are not subject to all the mandates and regulations and requirements that the authors of the law put on the individual market, making it much more expensive. Those costs are built in, they're structural, they will stay there. It doesn't matter how much you subsidize them, the cost will just keep going up and
again,
up and up.
The full burden of guaranteed issues on the individual markets as well, right? Mr. Bragdon, talk about the lack of access to disabled children because they're being crowded out by single able-bodied working-age childless adults. I mean, talk about that outrage because that's not discussed enough.
I think one of the most perverse parts of Medicaid expansion in Obamacare is when Obamacare loaded the lifeboats, it said non-working men first, and then pregnant women, the elderly, disabled, kids with disabilities later. And it creates this incredibly perverse system, as you talked about, that contorts all sorts of money laundering schemes by states to maximize the expansion population, but it also then incentivizes that kids with disabilities or adults with disabilities are on the chopping block first. Because when states need to save money, they save more by cutting services to those individuals.
Is it also true that Biden allowed providers to charge commercial rates for the Medicaid expansion population?
Correct. So you have this dynamic.
So I mean, just the providers themselves get reimbursed more for an adult, healthy adult versus a disabled child, correct? So what do you think providers are going to do?
Correct. They're going to respond to financial incentives. And so if I make more money by serving a Medicaid patient of an able-bodied adult than I would an elderly person or disabled person on Medicare, of course they're going to be prioritized.
Dr. Blaze, talk a little bit about the impact of putting all the guaranteed issue cost burden on the exchanges, basically, correct?
Yeah, I mean,
Because before individual, they had the high-risk pools. And as an employer, that worked beautifully. When we would have somebody they'd call lasered out of our plan, somebody who had cancer or something, they would go into high-risk pool, exact same coverage. I mean, same deductible, all that type of thing, same rates. It worked great. And then when they got well, they'd come back onto our plan. But go ahead.
yeah, so there are 35 states that had high-risk pools, and that's if the person couldn't get private health insurance, they would apply to the state high-risk pool, and they would get coverage through the high-risk pool, and that was subsidized. The critique of high-risk pools was they weren't adequately funded. What we could have done instead of the gigantic Obamacare regulatory and subsidy structure, which inflated premiums for everyone, is just provide more funding for state high-risk pools, but we chose a different approach.
I think they were funded well in Wisconsin. And anyway, that's really got to be the first step. You know, we talk about free market reforms. We have to do that as the way to make sure that people with pre-existing conditions get coverage. I mean, we've got to tweak those high-risk pools, but we have to first reinstitute them, correct?
Yeah.
It's kind of like, that's sort of the first step of things we have to do.
Yeah, I think.
Which, again, when you dismantle something, it's kind of a pain to have to reestablish it, but that's what we have to do.
Yeah, I think if you're going to revisit Obamacare's architecture and really lower premiums, then reinstating high-risk pools and having them funded is a reasonable action.
Well, if you don't revisit Obamacare's architecture, you're not going to bring down costs.
No, Obamacare inflated costs significantly in the individual market, and one of these the medical loss ratio. I mean, one of the things that we've seen, because we have all of these phantom enrollees, and so insurers have made a lot of money on phantom enrollees, but the minimum loss ratio means that they need to spend that premium revenue. So they have very bad incentives to look the other way on extremely high costs on the other end. So you're getting very inflated costs for high utilizers that benefit providers and big hospital systems, and there's a lot of sort of corrupt behavioral health and addiction treatment services that are taking advantage of that system.
That you have to explain. I think I sort of understand, but that's interesting. Senator Ernst, are you ready to go?